Boa tarde. Muito obrigado pelo convite, mas eu vou falar em inglês, senão, leva 3 horas para mim falar em português. Okay, so I'm sorry you've got me twice today, but I will hopefully try and fill in Luis's shoes because unfortunately he couldn't be here today. So I'm going to give this talk, and I apologize in advance to all the virologists here because it's going to be quite clinical. Okay, so this is resistance considerations when switching in failing regimes. Okay, so there are my disclosures. So I'm going to talk about this, staying on the same drugs with virological failure. Can you do that? What about switching for resistance when the resistance is either known or it's suspected? You haven't done a test, but somebody may have had virological failure in the past. And I'm going to talk about when you're switching when you're undetectable, but you've had failure in the past, or you're detectable at the time. And also a little bit about the role of recycling nucleosides. Pro-viral DNA. There's lots of people in the audience that are a lot more than me, but I'm going to give you my angle on pro-viral DNA. And at the very end, a little bit on MDR HIV, multi-drug resistance. Now, we did this study on big F TAF, and we looked at patients from 3 big studies, and we looked at people who had virological rebound, and you can see the data here, the virological rebound to more than 1,000 after they were undetectable. And we had 110 rebounds in 96 people out of all of these participants. First of all, we saw no treatment-emergent resistance, so probably they just stopped their drug and didn't take it once a week. And when we started with that, most of these people, you can see, resuppressed. Some of them had continuing viremia, probably not taking their drugs, and 11 of them disappeared, so we couldn't find them. But you can, especially with triple combination, second-generation integrases, and I'm sure you could do the same with TLD, that if you see them rebound, one of the things that we do is give adherence support, of course, and try and find out what's happened, and then restart the drug, and we send off resistance tests. But usually, with things like BF-TAF or with dolutegravir triple combinations, we don't see resistant mutations. Now, what about switching for resistance when you think they've either got resistance because they've had virological failure in the past, or you know they have? So let's look at those people who at the moment, they're undetectable, but they've got some resistance data from the past, and you're thinking, can I switch the drug? Is it better that I can do something, or shall I leave them there? So let's look at that. So let's look at 3TC resistance and switch. Now, a lot of people are moving now towards dual combinations, or they're giving patients dual combinations that might have 3TC in, or they're giving them other combinations, okay, with 3 drugs with 3TC. Ah, back here, okay. So this is the Big Star cohort, where it's a big observational cohort study of about nearly 1,000 people, and they had genotype data on about half. And if you look at the bottom, I think this is the most important part of this slide. Pre-existing resistant mutations, no or yes, okay? So these are people who have actually switched to BF-TAF from their previous regimen, usually because they want simplification. And if you look here, if they've had pre-existing resistant mutations, there was no difference in the less than 50 copies at a year. Now, if you look at these people who have TAMs with an M184V, you can see they also do well. And even if they've got 3 TAMs here with an M184V, they do extremely well. So it appears that if you decide that somebody needs to go on, say, a single drug regimen, and they've been on some complicated regimen, but they've had a 3TC mutation in the past, this looks like it'll work. And it's probably because Biktarvy plus TAF alone is probably enough. Okay, I'm not sure about that, but it probably is. So here's some more data on 3 drugs with historic 3TC resistance, and a lot of this comes out of the Biktarvy data about people switching to it. And basically, again, if you look down this column here, with all the different types of different resistant mutation patterns, most of them get very, very good results. So I think we should relax. If someone's got an M184V or I in the past, and they're undetectable at the moment, and you want to switch them to a Biktarvy, and I'm sure you could do the same with DTG, TDF, 3TC, I wouldn't be concerned about the 184V mutant. And I'm going to show you some data later. Maybe we shouldn't be too worried about other TAMs as well, because you can see even from this, it didn't really make a big difference. Can you lose these mutations over time? And one of the theories why maybe previous 3TC resistance doesn't matter is that actually they disappear from the reservoir. And here's some proviral DNA studies, and this filter here is whether you're going to look all the way down to does the 3TC mutant occupy at least 2%, and the other filter is at 5%. And basically, you can see over time, over several years, the 3TC mutations seem to disappear. And this magic 6 years, you might remember a raltegravir study from the past, where those who'd been on raltegravir, who switched to raltegravir, but had a 3TC, had been undetectable for at least 6 years with 3TC mutations in the past, they didn't rebound. And people think that this is the reason that that patients who have got 184 in their proviral DNA, over the years, they lose it. Why that is, it's really interesting. I can't really give a reason, but it looks this way. Now, imagine you've had prior virological failure. So you get this is always a nightmare. A patient comes to your clinic for the first time, and you have very little data, and you want to give them, and they're undetectable on a therapy, and you think to yourself, I want to switch them off, especially if they're on ephedrins, I want to switch them onto something more modern or new. And you say, where have you been? I've been to this clinic, that clinic, I live here, I live there. And you try and get some data. And you find that at some stage they'd had virological failure on something, and you're not quite sure what to do. And I mean, many of us are doing proviral DNA. I'll come back to that later. But if you're in the world where you can't get proviral DNA, what can you do? Well, this was a study that we did and published in the New England Journal. And basically, if you can see, people had arrived on boosted PI because they'd failed on ephedrins before. They'd had virological failure on ephedrins, no resistance test done, just switch straight to a boosted PI. Now, these days, we're trying to move away from boosted PIs because of all the drug interactions. And also, they're a bit more metabolically not very favorable. So we're trying to move away. So in this study, what happened was they were randomized to be given dolutegravir in 2 nucleosides. Almost all of them had TDF, 3TC, or they continued on the drug. So what was the outcome? So this is really interesting. These patients had prior virological failure, and actually they all did well. So again, if you've had prior virological failure and you're on a boosted PI, especially prior non-nucleosides, and you're on a boosted PI and you want to move them off the boosted PI, but you don't have any resistance data from the past, this is something you can do. And what we do in our clinic when we do this, we monitor them more carefully. Rather than 6 monthly viral loads, we do 3 monthly for a year just to check that everything's okay. Now, what about this proviral DNA? Well, the landscape's not uniform, and I mean, I'm very happy in the end you can have all these slides to look at this, but basically the problem is there are sort of 2 types of proviral DNA. One that you can replicate and one that's junk, that's just bits of it stuck in there. And the problem is if you've got bits of junk with a resistant mutation in that's not significant, and you look and you find a resistant mutation, you're not quite sure whether that's going to be the virus that would come out if you stop therapy. Okay, So it might provide useful information, and we started to use it quite a lot, and now we're wondering, now we're getting the results back, whether this is really good. But if there's no complete clinical history, you could use it. If it shows archived antiretroviral resistance, it could be some guidance, right? It could be, it's not categoric that what you see in the proviral DNA is actually going to impact you, because there's limited sensitivity. And this looks confusing, but it's not. So what they did is, they took cells from 2017 and from the same patients, cells from 2020. And they looked at the proviral DNA in 2017 and the 2020. And when you look, let's just look at the green, only in 2017, you can see that there are various mutations found, okay? And then when you look in 2020, there's a different number of them found. In other words, it's not consistent. And sometimes that they are in both, that's great, but often, right, you find a discrepancy. And here, these are patients who had no mutations found in either. But you can see it's very different. You should have this should all be consistent, all of this, but it's not. And in 28% of the cases, there was no consistency at all. Even though, and these were 3-year apart samples, you might say they've lost some of the mutations over the time, and that's why you've got the discrepancy. But some of them actually had more mutations in 2020 than in 2017. So I'm not quite sure where we're going to go with this. And here's a big registry looking again at proviral DNA, and they're looking at various thresholds of what to find. And basically, they think that if you've got more than 5% of a mutation found in the proviral DNA, it's significant. So if your M184V in your proviral DNA is 7 or 8%, they think that's important. If it's 4% or 3%, they think it's not. So I don't know yet, but this is a big registry looking at that. So let's take all that proviral DNA and move it into a study. And this was a landmark study that came out of Croy, that Nick Payton presented, and it's called the CARES study. And it's basically a study from lots of sites in Africa, Asia, and mainly, in Africa, and there's 500 patients. Now, they were all virologically suppressed, okay, so they were undetectable. And they were on dolutegravir and 2 nucleosides, or on efavirenz mainly, or 2 nucleosides, and they'd never failed therapy. So these are ideal patients. And they switched them to continuing their therapy, or gave them long-acting cabotegravir and rilpivirine. And interestingly, as you know, most people are saying you have to monitor these patients every 2 months, you have to do the viral load, you have to make sure they don't have virological failure. But in this study, they only monitor them every 6 months. And interestingly, if you look at the baseline characteristics here, over here, you can see that 57% of them had subtype A1. Now, A1 is a subtype that most of us, before this study, felt we shouldn't be giving cabrilpivirine to, because there tended to be a higher failure rate in subtype A1. We don't think that's the case now, and we think it's A6. And look at this, 74% had prior non-nucleoside exposure, and when they looked at the proviral DNA, now 10% had rilpivirine resistance, and 8% had cab resistance. Yet, look at the results. Nearly 97% basically in both of them were virologically suppressed, and 1 patient on cabrilpivirine had virological failure, which is about the same as we've seen in all the clinical trials. Now, if this archived proviral DNA was really important, then I think we'd have seen more failures. So I don't know. So this is a clinical use of archived proviral DNA. Also, I need to know what exactly, which mutations they had. They did have some E138s in that study, but it would be nice to know. So basically, and if you look at your situation here in Brazil, and we're looking at ours, why are we monitoring every 2 months when 6 monthly look good? Why are we worrying about subtype A1 or even BMI? Now we use long needles, okay? So all of that now is interesting. I mean, if they had baseline rilpivirine or cabotegravir in standard sequencing, I wouldn't, obviously you wouldn't give it. But the proviral DNA here, I'm not sure it really helped at all, although that was retrospectively done, of course. Now, what do you do when a patient comes in with virological failure and you want to switch them? Okay, and they're on a non-nucleoside. I would think that most patients, like they are in the UK, are moving off non-nucleosides, although now we've switched a lot of patients to doravirine. But this is interesting. If you have virological failure, can you recycle the nucleosides? So the Nadia trial was another landmark trial, and basically they had all these patients with virological failure. Look at this list down here, if you can see it down there. K65R in half of them, right? M184V in nearly all of them. High and intermediate resistance to all of these other things. So they switched them to what we would have done in the past, to a boosted PI, because, you know, if you've failed on a non-nucleoside, let's go to that. But they also randomized them to dolutegravir, and they used two different backgrounds. They either used 3TC-TDF, or they used zidovudine 3TC, which was a backbone that WHO liked in second line at the time. And basically, whatever you did, the patients actually performed very well indeed. Remember, these are patients who have got virological failure. So dolutegravir and darunavir, very well. And if you switch them to TDF or zidovudine, they also did okay. But when you look at and that's at week 48, but when you look at week 96, actually at the bottom here, you can see that actually it's not doing so well. And there was some integrase emergent resistance, which we have to be careful of. So here's all the subgroup analysis. And basically, when you look down all of these resistant mutations down here, and you see the number of people that have done well, the one place where they haven't done well is if they're on zidovudine. Okay, they haven't done quite as well. But with the tenofovir, they've all done extremely well. So it meant that that K65R and other TAMs that they had was not impacting on switching to dolutegravir plus Truvada and 3TC. So let me just summarize what they got from the drug resistance patterns. If you didn't have a 180, if you had nothing, no 184V or K65R, TDF looked better, probably because of toxicity, etc. If you had the 184V alone, TDF looked a bit better than zidovudine. But as we know that M184V does enhance susceptibility to both zidovudine and tenofovir. Okay, so if you have the K65R and the 184V, again a bit better for tenofovir because of these interactions, of these mutations on the susceptibility of other drugs. So it's quite complex, this explanation that they've come out with, but it's very interesting how it's been useful. If we look at the patients with dolutegravir resistant mutations, and you know this is becoming an issue that we're concentrating on in the world, and Ricardo showed some data from Brazil, most of them were in the patients on the zidovudine arm. But there were 3 here, and you can see them at the bottom, who were on the TDF arm. So switching to this has a small price, right? It has a small price. Some of the patients will develop resistance to integrase, but very few of them. This is 3 out of, there's 250 in each arm, so that's at week 96. So the lessons are that you can switch people from non-nuke regimens that they're failing on to dolutegravir and 2 nucleosides. Dolutegravir resistant remains a slight concern, but if you have got worries or issues, darunavir seems to work really well. And I wouldn't anymore give zidovudine 3TC. I'd recycle the tenofovir all the time. So MDR HIV, well, what do you do if someone's got multi-drug resistance? So first of all, it's really strange. We've got no fixed definition of it, you know. If you look at all the guidelines, there's none in the US guidelines. The European guidelines, which I sit on, say multi-class resistant to more than 2 classes. You can't construct a regimen. And the BEVA, which I also sit on, we say individuals with limited or no therapeutic options when a suppressive regimen cannot be constructed. Now, the good news is that with newer drugs, we're going to get even less patients with MDR HIV. Now, and this is one thing that if you've never had an integrase before, here's some data on patients who switched and they simplified. They were on lots of drugs trying to control their multi-drug resistant HIV. They were on atravarine, or they were on, you can see here what they were all on actually. You can see in this corner here. They're on all sorts. Doravirine, dolutegravir, atravarine or rilpivirine, with NNRTIs, with all sorts of different combinations. And you know, in your clinic, if you look at your patients with MDR, if you've got these drugs available, you mix them all up and put them together. So what did this Gilead do? They did this study, and they basically gave 2 different doses of lenacapavir daily. So this is a daily oral versus continuing their baseline. Now, the numbers aren't big here, right? In the phase 2 extension, they're going to go to 50 milligram. Well, anyway, what were the results? Okay. So when you see this, they all did very well. Both doses did very well. Why are they going to 50 milligrams rather than stick with 25? Probably because if you get any drug interaction, right, it's better to have the higher dose, and the higher dose was just as well tolerated, as you can see here, as the lower dose. So if you've got somebody with MDR HIV on a complicated number of pills and tablets or on a boosted PI, and you can get access to lenacapavir, then that, with bictegravir alone, appears to be very efficacious. Now, let me say, we've been saying for years and years and years, why can't we get bictegravir on its own? Why is it always fixed with TAF and FTC? For those, I know it's not easily available here, but now at least they've done a study with it on its own. And I think that they should really do a study of BIC plus TAF on its own, because I think that will work just as well, and you would be cheaper and easier, but never mind. But not in these patients. These patients needed a drug with a new mechanism action. And just one word of warning, I suppose, is about resistance in resource-limited settings. There's lots of, and Luis contributed to this from Mexico, that it is starting to increase. But actually, when you look at it overall, it's over the 20 million or so people who are receiving these drugs, it's still a very low percent. And all I would say is that from all these cohorts here, where you look at these large numbers, right, but these are only the numbers. When you see 22% integrase resistance, no. These are people who've failed therapy, who've had a blood sample that's gone to the lab. Right? These aren't everybody on an integrase. We've really got to be very careful when we look at numerators from this data. Otherwise, what you do, you start panicking, going, oh, 25% integrase resistance. No. It's 25% of those people who've had a blood sample, who are failing therapy, and it's actually got to the lab, and they're doing that. So just, it really is very, very, and I think the best is from Malawi, 0.07%. That's probably about right. Totally overall, this 0.07% is probably overall what we're seeing. But if you don't have surveillance in your country for this, then you might miss a slow rise in the resistance to dolutegravir or bictegravir. So if you do have resistance to integrase, can you give twice daily dolutegravir? And this is really old data. It's 10 years old now, and people are doing this for those patients with multi-drug HIV who have got integrase resistance. And basically, it all depends what mutations you have. And if you can see here, if you've got the Q148 and 2 or more, well, it's still worth a go, but you're not going to do very well. If you haven't got a 148, you've got other mutations, you seem to do pretty well. But it's very small numbers. It's the Viking 3 study, but and I think it's interesting. But I've never seen a big study looking at this, because it's quite difficult to do, to give double dose. But remember, we're very wedded. We're very stuck now with integrases in the world. And if you think about what's going on, about how many people are on them, what it would take now to start doing resistance tests in Africa, finding they've got resistance to the dolutegravir as a public health thing, and then saying, oh, we're going to give you double dose, it would be quite extraordinary. So I think that this is really for those people who have access to resistance tests, access to a lot of therapies, and access to other things. And probably it'd be better to give combination drugs. So if you've got no options, well, I mean, you're looking at some of these drugs like I am, saying they're not available. We can't get ibalizumab. Fostemsavir we can get hold of. Islatravir we can't. Lenacapavir we can get hold of with a special request, and BNAbs we can't. And I am going to show some data on lenacapavir and BNAbs together in the final talk. So this is a way of combining drugs with new models, new modes, new ways of activity together to try and treat these patients. But anyway, really, if you have one of these patients, it's much better to send them somewhere to people who've got big experience of treating MDR-TB, and it may be MDR-HIV, because I think they are very difficult. And so finally, the take-home points. Firstly, our idea of how resistance affects efficacy is changing, right? So number one, what do these mutations really mean, especially nucleoside mutations? Secondly, how do we really, we can recycle these nucleosides, which is really interesting with second-generation instis. What's the role of proviral DNA? I don't think it's been resolved yet, and maybe what we're measuring needs to be refined. We must stay aware of insti resistance across the globe, and actually there's some now novel long-acting compounds, or even shorter-acting compounds, that may change the landscape with MDR-HIV. And with that, I'd like to thank you very much.